Episode 29?
29.
Okay.
Yep.
I should ask you that before we hit record. Well, we have a great interview for you all today. We have Dr. Tarun Kapoor, who is the Executive Vice President and Chief Digital Transformation Officer at Virtua Health. Vic, you brought the story to us 2 weeks ago from Modern Healthcare.
Yeah.
That Virtua Health was embarking in the world of AI and behavioral health, and we had a pretty spirited conversation about it.
Yeah.
And then our buddy Bruce Brandis listened to the show, connected us via email with Dr. Kapoor, and we just spoke to him.
Yeah. I mean, I think the podcast is working very well. Like we found this really innovator doing interesting stuff with AI, talked about it kind of in the abstract, and now we have him on the show today, which is going to be great.
Yeah. So we won't take up too much time before we let you hear the interview, but I will say it was an absolute pleasure speaking with him. We'll debrief more after the interview, but what a guy. And actually, you know, when we talk to people actually in the industry who are willing to have these kinds of conversations, especially with investors and innovators like ourselves, it does boost me up a little bit and make me more excited about, you know, working in this industry.
Yeah. Yeah. We can debrief about it, but I think he's doing everything that he thinks is right, and it's pretty exciting.
Awesome. So without further ado, here's our interview with Dr. Tarun Kapoor. All right, welcome to the show, Dr. Tarun Kapoor from Virtua Health. Thanks for being here with us.
Thank you so much, gentlemen. Appreciate it.
So the way that this all came about is we did a show a couple weeks back where we were covering some things in the AI space, and thankfully, we don't have zero listeners. Our buddy Bruce Brandis, who's a great healthcare entrepreneur, sent us an email and said, "Hey, you did a story. You were talking about my buddy who rolled out that program at Virtua Health with the Wobot, and looped you right into the email and said you guys should talk. And you were gracious enough to offer the opportunity to speak with us today, which we really appreciate."
I really appreciate the opportunity to talk to you all as well, and thank you for the podcast session. I really enjoyed it. Bruce pinged me and said, "Take a listen to the whole thing, but definitely listen around minute 45." Right. I listened in to the whole thing. I was like, "Oh, this is really interesting." And then I said, "Well, wait a minute. How is this going to pivot into the stuff we're doing with Wobot?" And you pivoted to the stuff we were doing with Wobot. And I said to myself, I like their framing of it, but that's not exactly what we're doing. And so I reached out and I said, "Hey, just wanted to talk through, this is how we're thinking about it, because some of the things that you were discussing as your concern and friction points, trust me, I've kept me plenty busy thinking about this." So I just wanted to say, let's talk a little bit more, because I think there's such an opportunity to think about this collectively, both from a healthcare provider's perspective, but an entrepreneurial space. And how do we meet somewhere in between?
Yeah. I think it's great that you can spend some time with us. I mean, we're trying to sort of read the tea leaves from afar and try to give a balanced report, but it's really great to talk to you right on the inside and sort of understanding how it's actually working for providers, for patients in a live setting, which is incredible. So thanks for taking the time.
Well, of course. So maybe one of the things that we had chatted about offline that I thought was important to clarify, and exactly to a very important that you raised, was Gen AI versus the other techniques in AI.
Yes.
And I think there's tremendous promise, remarkable promise for Gen AI. In healthcare, though, we're not there yet.
Yep.
Not at least for straight out clinical use cases. And so one of the things that we're trying to use, and specifically with the Wobot, and one step back for people who didn't hear the initial episode when we talked about this, Wobot is what we considered a relational agent or adjunctive agent that a patient who's suffering from mild to moderate depression can use when they're offline from their clinician. And in the use cases that we're going to be using here, let's say a primary care doctor, nurse practitioner, et cetera, would see the patient and say, "Well, I see you're experiencing these symptoms. I think you would benefit from maybe seeing one of our therapists. maybe possibly starting medication. And I would also like you to start doing some exercises around a technique called CBT, cognitive behavioral therapy. And the beauty of CBT is it changes your mindset of how you react to things. That's where we're layering Wobot. All right. So the clinician is still in the loop, but a lot of the work is being done offline because you spend 99.9% of your life outside the clinician's office, or at least hopefully you do. and, and so that's where we're using Wobot. But it is really more of a knowledge graph that's supplemented with machine learning. It is not generating new insights or new responses back and forth. It's a much more controlled, scripted interaction for now. I do think, though, there are going to be use cases for Gen AI. So I think a really important takeaway for me was when I'm speaking about AI in healthcare, need to make it very clear what is Gen AI and what is not Gen AI. So I think that was one of a learning for me.
Yeah, I think that's a really important distinction. A couple things I just want to frame up for our listeners. Vic and I, we get on this show and we're just two investors reading the stories and trying to sort of process all this stuff. But what we're trying to do here as investors is we're trying to collaborate with the industry to advance the way that we operate our industry and the way that we care for patients. And, even outside of the work that we do in venture, both Vic and I are involved in a variety of different ways. I'm on the board of HFMA, for example, and trying to work with providers, especially on how to really develop a culture that is more embracing of innovation and can absorb innovation. So I think the first thing both Vic and I want to do is just tip our hat to you and credit you for being a pioneer here and working on ways to integrate artificial intelligence into the clinical setting. And then want to also say thank you for making the really important distinction between all the different forms of AI that are out there, remote patient, like robots that are processing, from an automation perspective, machine learning that's working on very prescriptive sets of data versus LLMs, right, that are generating things in a way that we can't really totally predict and are and can have hallucinations or provide feedback that is not necessarily correct, as I think was the situation that happened with the eating disorder organization. I think that was what sort of happened there. Is that your understanding of that?
Yes, I think you referenced the Wall Street Journal article, which talked about a mental health app. And of note, there are, I believe, like 10,000 mental health apps that are out there in the ecosystem. And yes, it was very scripted responses that they were originally having. They switched over to an LLM model, and the LLM started doing LLM stuff. And I think that's the other thing that is really also important conversation in healthcare. There are different temperatures for LLMs. You can have warm LLMs who are meant to be creative. Problem with creativity is that sometimes you can confabulate. Or you can have very cold LLMs, and they don't do a great job of a demonstration at a dev day, right? Because it's not super creative. It's not able to convert something into iambic pentameter or a rap, but it's going to be much more factual. And so I think we need to be also thoughtful in asking these critical questions. Where's the temperature on your LLM? What LLM should you be using, if you even should be using an LLM? Those are the thought-provoking questions I think good investors and good clinicians should be asking and having that dialogue.
Yeah, and Dr. Kapoor, I want to just sort of go back to what Marcus was saying in the reference of behavioral health in the clinic. So one of your titles is, I think, digital transformation officer or similar. Sorry if I butchered that. But the situation health systems find themselves in around a lot of disease states, but let's just take behavioral health because we're talking about that now, is there's more patient demand for treatment than really can be serviced by the clinicians. And it's very challenging to find new doctors and nurses and psychiatrists and counselors. And so what I want to really understand from you is in your spot as digital transformation officer, how do you balance that patient care, patient safety, responsibility is where I think it would fall, with trying to bring more available treatments, more frequent treatments, more services to patients? There's a balance there. And so maybe talk about that, and then how you thought about figuring out which of these 10,000 potential apps could be useful, maybe the origin story of how you decided this even would be something to look into, and then what was that process like to evaluate?
Let me propose a model of how we look at it. Now, the problem with models is that you go to first principles. Models are not good things to use, right? You're supposed to use net new. But if you don't start with something, you're just grasping at straws.
Yeah.
So here's how I generally try to think about it, and then I try to see if there are exceptions that require me to change the model. So just think of a straight 2x2, and I'm not the one who created with this. Lots of folks have talked about this. On the one axis is the consequences of getting it wrong. And then on the other one is the volume of decisions that need to be made. So if there's low consequences of getting something wrong from a clinical outcome, regardless of the volumes, automation is actually a place to go after, right? So in healthcare, let's say, for example, I want to put an automation tool around patient payments. I'm not saying that getting an incorrect bill is not painless, right? We can apologize and say we made that mistake, but the clinical consequence is relatively low.
Yeah, patient safety is not at risk, for instance.
Not at risk. Yeah. So go nuts on automation in straight administrative spaces. The downside of that is, from an entrepreneurial perspective, is like it's a very crowded space. And that's not where the big pain points are in terms of staffing. So the pain points are on the side where humans, and specifically very highly trained and usually highly compensated clinicians, have to be involved with. But there's therefore consequences. And
that's where the impact is, probably. I mean, if you can do it right, correctly. Yeah.
100%. So the fallback is, well, we're going to still have a human in the loop. And I think that's going to be a reasonable approach for the next couple of years. But we're going to start running into some problems, and we're already in some of them right now, and they're only going to extend and exacerbate over the next couple of years. And let me give an example that Kaveh Safavi's work from Accenture talks about. In the next 5 to 10 years, Sweden will need 25% of its workforce to work in healthcare in order to care for its population.
Wow. Wow.
Finland will need 100% of its workforce to work in healthcare to care for its population.
Wow.
So if you're always going to have a human in the loop, you're not going to solve the problem in the long run. Oh, and there's one other conundrum. Automation tends to solve the easier things first. It replaces tasks. What does that leave behind? The hard stuff for an already diminishing workforce who's already burnt out. So at some point, we're going to have to get to automation anyway, even with very complex things. And the model that I've been thinking through, as an analogy, it's a little bit further of us in healthcare, is autonomous cars. Right. So in 2017, Rand Corporation, which is not a bunch of bleeding heart liberals, right, said if we move to autonomous cars sooner rather than later, we will be able to decrease the death rate by 50%. And we have about 35,000 to 40,000 motor vehicle accidents every year. 90% of motor vehicle deaths per year. 90% are human-related accidents. If we could cut that down to 15,000 a year, shouldn't we do that? But here's the problem. Are you going to be comfortable if your family member died in a motor vehicle accident where the machine made a mistake? And that is the societal conundrum that we're dealing with autonomous vehicle, which is going to also tie right in, I think, into medical technology and healthcare. We know our clinicians make mistakes. Medical errors is one of the leading top 5 causes of death in the United States. If we can decrease that number by 50%, but it was an algorithm that made a mistake, not a human, can we as society live with that? And I don't have an answer to that.
It's the right question to ask, though.
Yeah, yeah. I love your automated car example, because I use a related example of analog brakes a lot. Like I consider myself a above average driver, meaning like I drive fast and I think have good response time. I'll get a ticket once in a while. Hopefully no police are listening. But I want analog brakes. It has nothing to do with the skill of my driving. It has to do with the computer can assess the situation and know to not lock the brakes and pump them much more quickly than a human could ever do. And I use that example with doctors a lot because doctors and nurses and clinicians, they are the expert, certainly. But there may be situations where a computer could do something and not get tired and evaluate a bunch of things that the doc decided what the algorithm should be, but then it gets implemented with that. And I really think your question is exactly the right question, really for our society, is how do we balance this between a empathetic caregiver, a doc, a nurse, another extender, making a decision that's best understanding the entire patient situation with helping them scale and deliver sort of more repeatable outcomes. That's a balance that we have to figure out as a society, I think.
Yeah, and Vic and Marcus, I'm going to throw another conundrum into there, right? And that is exponential growth of knowledge across the board, but especially in the medical field. Beginning of the 19th century, medical knowledge doubling every 50 years or so. So within a career, a clinician could retrain themselves.
Mm-hmm.
The current number for medical knowledge doubling is around 45 to 50 days. No human being, regardless of how bright, how well trained, can keep up. To the point where I think there's going to be some situations where we can make an argument, maybe not today, but maybe in the next year, 2, 3 years, you're actually dangerous not if you're not using machine.
Right. Right.
And there will be case law that will be established at some point where someone is going to file a lawsuit to say, I'm suing this health system or someone else because they didn't even use the machine.
Yeah, they didn't know about some clinical study that could have been available to me because they didn't read that particular journal article, except there are thousands of articles that come out every week.
Example I'll give you, we're using augmented reality to assist our GI doctors when doing a screening colonoscopy.
Mm-hmm.
It's an extra set of eyes. What do you have to lose?
Right.
When we demoed it to the executive team, number one thing that the executive team came up and asked me, do I need to repeat my colonoscopy that I had a couple years ago? So the other thing is, it's like, well, the clinicians say, no, my eyes are really good. And I agree with you. You get it 99.99% right. But what if it's my colon?
Right.
And so we're starting to arrange this, or trying to create an environment where our clinician can not be overburdened and not be questioned for using the technology, but also feeling that they're protected while they're using the technology. So there's societal, governmental, regulatory pieces of it, but I think this is at least a way of thinking about it.
Yeah, so maybe give us like 30 seconds of your background. I think you came up as a hospitalist before you entered this role. Talk about that perspective, and then how does your system or any health system, how should they think about navigating these issues, given the regulatory environment we're in and the economic situation we're in, where they need to figure out a way to make the clinicians more effective, more efficient, deliver better and more efficient care.
Not lose money.
Yeah, not lose money.
Yeah, rule number 1, don't lose money. If you're losing money, see rule number 2.
Yeah.
We're not going to cut our way out of this. And that historically has been traditional healthcare delivery models to say, well, we're going to consolidate and then we're going to find safety in numbers. I do think we are a very interesting inflection point in healthcare delivery in the United States where there are actually, for the first time, winners and losers. It's starting to happen.
Mm-hmm.
Now, it tends to be a lot of the losers have been in the smaller rural communities, and that is not a good answer either. But now you're even seeing those losers in the reasonably population dense or historically well-doing areas. So, what we take approach here at Virtua is a model that came out of Silicon Valley, and that is we go ahead and we try to make a funding decision internally to innovate with purpose. It's just not saying let's run a whole bunch of experiments and see what sticks. What is the problem that we're trying to solve? Our team, our digital transformation office, our team, we will partner with the traditional operator. We try to help you figure out in 6 months. We bring the funding. If we can prove a concept that we can make this thing work after 12 months, 18 months, it goes into your operational budget and your new way of doing business. If you don't like it after that window, we kill it. Something health systems aren't really good at doing is stopping pilots.
Yeah.
And so there have been pilots that I said, this is such a great idea. The timing wasn't right.
Mm-hmm.
We were just too far ahead of the market on that. And so you come back to it again, again, and again. And then maybe 3 years later, that was the right idea. If you are not doing that, you're going to get left behind. It's just a reality.
And so what is the discussion like with the leader of the practice? Maybe it's a behavioral health practice, maybe it's a primary care practice. How do they frame it for you before you know that's going to be Wobot? We're going to go find a tool. How is that discussion held, or what are the benchmarks? Or how do you think about an RFP process, or how do you evaluate these things?
First thing we look at is when I work with the clinicians, what is the problem you're trying to solve? And then we ask them 5 more times when they tell the problem, so, well, is that really the problem? But once we get to an idea of what the problem we're trying to solve here, and with Wobot, for example, we're saying we're not trying to cure depression and anxiety without your help. You already have seen these patients. You want your patients to get better faster. That's the problem we're trying to solve. Then why don't we try to accelerate the healing process for all the time that they're not with you in the office? So we change the argument as saying it's not here to replace you. It's actually here to make the next visit even more productive because the patient has progressed. The patient likes that. The clinician likes that, right? Everyone feels good about that. Then the other piece that we started working through is how fast can we get to market? And this is, I think, the key thing that I would tell the audience to take away. Just because something may not be perfect, still mean it can be safe. A lot of times in healthcare, we hide behind the Latin phrase, prima non nocere. First of all, do no harm. But doing no harm and not doing something are not synonymous. And that's where a lot of people hide. So as long as we can prove that it's safe, then we can try to pull off efficacy. That's just exactly how the FDA does it too. First, they look for safety, then they look for efficacy, which is why I think you're seeing so many parallels between digital therapeutics and pharmaceutical therapeutics, right? They're trying to take that approach. We could talk about pair and where it went sideways with pair, but that's how we try to look at it. The number one thing I always talk about with physicians to understand, what is their fear point? What about you? What about this problem? What about the solution worries you the most? And invariably, it's fear that this problem will lead to a bad outcome. What if we prove it with 5 patients that we watch like hawks that we want to have a bad outcome? Then can we go to 10? Then can we go to 50? That's how I recommend working with health systems.
I'd love to actually take you up on that and talk a little bit more about digital therapeutics. We did a whole episode on the pair implosion and got a lot of feedback on that, and ended up having a friend of ours come on the show, Aaron Ghani, who's the founder of Behave VR, and in a similar way to you, help clarify sort of the situation in the digital therapeutic space. And sort of what we left that conversation understanding is that there is a lack of framework between the FDA and CMS on how to actually position, package, and then ultimately code digital therapeutics. So I'm curious, in the Virtua Health digital transformation framework, where you're not necessarily looking just for, getting a new code where you can rebuild something, but you're looking to sort of change the overall care delivery model. Does that open up a system like Virtua Health to digital therapeutics in the way that an organization that doesn't have that sort of digital transformation lens can't really get there because they need a code attached to it? Or do you have the same sort of barriers to deploying digital therapeutics where you need the codes there to sort of really make a business case for it?
If you can't get paid to your solution, it's not going to end well, right? That's just the reality of it. What I'm most excited about the project that we're doing with Wobot is that this is the first time that a health system, a provider, is saying, I'm going in on this to actually see if we can prove a return on an investment. That we will then go to the insurers and say, we're vouching for this. We actually believe this is making an impact and will decrease your total cost of care. And so you're bringing a clinician or a group of clinicians to the group and say, look, this is what we're in here. That's the partnership between us and Wobot that doesn't get, I think, a lot of press on the innovation. A lot of the work has already been done on building the therapeutic out, right? They've done 12 randomized clinical trials, millions of minutes of patient interactions. The innovation here is on the business model. That, I think, is what is most exciting. And if we can prove this with the initial 500, maybe eventually 1,000 patients, and then get a code, great, in a fee-for-service environment. In a capitated environment where you're already managing the total cost of care, if it works, go after it.
Right.
And if I knew I had more of these tools that I should manage total cost of care well, I'm more open to taking risk.
Right.
And I think a lot of problems with the health systems out there is like, oh, I'm going to go take risk and then go figure out if I can manage it. Don't go in a casino if you don't know how to play blackjack. Right? It's just not going to work out well.
So let's double click maybe on that use case or business model. I love your 2x2 kind of quadrants. Is it right? It was our assessment from the outside that this was going to be more of a low acuity, fairly educated patient that is not, for instance, not a suicide risk, or maybe they have low levels of assessed anxiety and depression on intake, but the clinician, the human, puts them at a minor low triage, low acuity, low triage. Is that fair? And is that a part of the calculus at Virtua? Or how do you think about sort of segmenting the population?
That's exactly how we're starting with it. Like I tell you, there was lots of conversations around, wait a minute, the patient with severe depression, you mean we're going to exclude them?
Yeah.
Aren't the ones who need the tool the most? And so,
but the consequence could be much different with that patient. So that's why I like your 2x2 model. Like it could really help that patient, but also there's a lot riding on that interaction.
There is. The other question, though, I think about is, how is that patient communicating for help today anyway? Maybe they're posting on their social media network, and who's even watching that? Maybe they send us a message, they leave a phone call and say, hey, I'm not feeling good. I'm having these interviews. We may not get that message for a few hours. At least we have a relational agent that's actively listening word by word and can accelerate and say, hey, I'm noticing this. We need you to accelerate help. But you have to start with somewhere. And then if you can rapidly iterate to expand, then you start to get that viral adoption.
Yeah, and might it? I mean, this is me being a VC, right? So VCs are we quickly become experts, even though we have no knowledge in things. So that's but is it fair to say that this could open the aperture of the number of patients one clinician could bring in, and then it might highlight the subset that need, twice weekly sessions, and there might be another group that is you could come in once every 2 weeks, and the tool could help modulate that or help make sure I'm in the right category. Is that fair? Is that a future world that could be?
Absolutely. And so I'm going to tell you this little dirty secret inside of medicine. When you get hospitalized, what's in your discharge instructions? See your primary care doctor in 7 days. That's totally generic information. Maybe you should be seeing your primary care doctor in 24 hours. Maybe you should be seeing the cardiologist in 48. Maybe you don't need to see me for a month. If we can start to really understand where you are at any given point in your journey and then get you to a level of care, we're now making the usage of the very limited resources we have way more effective. And in some of these cases, and this is a hard one for health systems, we may need to see you at all.
Yeah, the goal is you don't want to see me at all, but in a fee-for-service world, that's a challenge.
Yeah,
it is a challenge. But am I also going to, if I'm going to see you for something very basic that we could have used in a different environment, whether it's in fee-for-service, whether you're capitated, you want to be using the limited resource you have to the maximum of capability. If we're not doing the stuff that only we can do, I don't know if that makes a lot of sense for us to be the jack of all trades. I think focusing, when I was in my first startup, the person who mentored me said to me over and over again, no one went out of business. No one went out of business because they focused too much.
That's a great thing to talk through. So I want to dig into your interpretation of how for-profits and nonprofits can work together in this loud environment. Of course, we're all following the news of OpenAI, the board dismissing the CEO. And it strikes me that you have an interesting perspective on this because you're in a nonprofit, Virtua Health, working with a for-profit Wobot, trying to create a business model for your practices, but also for Wobot at some level to make a lot of money and make a big impact. And so where's the line? How do you think about nonprofits and for-profits working together, particularly in healthcare? We see it happening in sort of AI, and whether it's going to come back together or not, it's showing me the tension between those two.
I don't think they have to be mutually exclusive mindsets. Even non-for-profits have to be able to generate some type of contribution margin.
Yeah, you got to pay your people. Yeah.
Right. No margin, no mission, as the statement goes. And so we also have these constraints that completely align with the true entrepreneurial for-profit world. The big difference is that we don't distribute earnings to our shareholders. We reinvest back in their community. But our communities are shareholders, so we're doing our best bet there. I actually look to see where's their synergy or alignment on the problem we're trying to solve and the ability to solve that problem. The other big thing I think that I spent a lot of time looking at is what is potential longevity of the startup versus the health system. Because the health systems, especially the not-for-profit health systems, typically the largest employers in many situations in their community. If we make really big, bad, risky bets to the point where we start to impact the employment status or ability to employ our local community, that can have a devastating impact. Not-for-profit, SPAC didn't work out so well. Oh, right. So that's where I look for some synergy of, or how to balance that out. The downside with that is that not-for-profit health systems were going to be drawn to the really large players. And so I think there's a balancing act of, say, I'm willing to work with someone smaller who's venture-backed, who may not have all the resources in the world, but I need to know, do they have a viable pathway forward? Are they reasonably capitalized? In your world, you may say they may be overcapitalized for the relative size. That gives me a tremendous reassurance that I'm not seeing something that they could make payroll.
Right.
Yeah.
And my product is gone.
Right.
Yeah.
That's how I would think about it.
Yeah, it's interesting. It strikes me that it's a alignment. Maybe it's all true in all business. Getting alignment on what are we trying to achieve, and making sure that we're aligned, whether it is two for-profits or a nonprofit and a for-profit. At some level, that can be the answer if you get that alignment. But there's a lot of discussion that has to be talked through about what are we trying to achieve. And then I think you're absolutely right. If this becomes an important part of the way you treat behavioral health, you want to make sure that this company can support you and isn't going to disappear. So I think that's helpful.
So I think we're gonna let you get back to work, but I did want to give you an opportunity to sort of leave our audience with maybe some insight and also some optimism for 2024. Big year ahead on a lot of different fronts. The technology landscape is going to totally explode. We can pretty safely predict that based on how the last 30 days have gone in the technology world. But also the healthcare world, right? I mean, is under tremendous pressure. And I think you're definitely setting an example for how, quite frankly, nonprofit health systems can navigate these very, very challenging times ahead. So what would sort of be, your message for our listeners?
So I should have done a better job and had asked ChatGPT to give me 5 or 10 things that a good healthcare executive should give for their year-end summary. Personally, I'm very excited that we're finally getting to a place in healthcare delivery where we're able to use some of these tools to meaningfully close some care gap. Give you a quick example. We found 12,000 people in our database who needed a colonoscopy based off of their age, just don't want to get it, right?
Yeah.
So we reach out to them, use our internal data to say, here's an alternative test that you can just do at home, send it in to us. A couple text messages, sent them a kit. Of those 12,000 people, 3,500 of them responded. Nearly 300 of them have positive results.
Wow.
That we are now actually getting in and helping them resolve and cure. This is a lot of fun now, right?
That's powerful.
All these tools are coming together to have meaningful outcomes and impact. I'm also really excited about some of the tools to make our lives easier as clinicians for each other. Because all we've done for the last 15, 20 years, it seems sometimes, it's just send it to the doctor. Send it to the doctor. And now we can say, doctor, I can actually help you get through your day a little bit better. And let doctors and nurse practitioners and clinicians do what they do best. And that is be hyper-technical or be hyper-humanistic. And in some cases, both. Those are some of the best things ahead. Tremendous headwinds, no doubt. And so this is maybe where I guess, what are the two A's? The electric, the altruist, and the effectiveness. So yeah. So I don't think it's an either nor.
Okay, that's positive.
I think that's great advice, and I just really want to say thanks for the work you're doing, really pioneering and blazing a trail of how can we bring technology tools to help clinicians and help patients It's incredible work, and there's hundreds of healthcare leaders that need to follow. So hopefully they will follow your lead.
I've learned from others. I just want to thank you for continuing the conversation. And that's the only way we're going to get better, or per the title of your podcast, take health further.
Yeah.
Amen.
Right.
Look, stay in touch. We'll be checking in to see how everything is going and what you're up to in 2024.
Yeah. When's the update point? When should we check back? Is it a 6 month? Is it 12 months? How long are you thinking about running it, like this first part?
Oh, we are really hoping to see results in the next 3 to 6 months. So we're just launching now, but
Okay.
glad to check with you maybe right around Q2.
Yeah. We'll
Okay.
circle back and see how it's going.
Tell you what we have.
Fantastic.
Okay, great.
All right. Have a good one.
Thanks.
Happy Thanksgiving. All right. We hope you enjoyed that. We're going to take a quick break and let Doug tell you about Jumpstart Foundry, and then we'll be back to debrief our conversation.
Thanks, guys, for the opportunity to talk about our pre-seed fund, Jumpstart Foundry. My name is Doug Edwards, CEO of Jumpstart Health Investors, the parent company of Jumpstart Foundry. We're so excited to be able to talk about early stage venture investing, certainly the need for us to change the crazy world of healthcare in the United States. We are spending 20% of our GDP, north of $4 trillion a year on healthcare with suboptimal outcomes. Jumpstart Foundry exists to help us find and identify and invest in innovative companies that are going to make a difference in healthcare in our country. Every year, Jumpstart Foundry invests a fund, raises a fund, and deploys that across 30, 40, 50 assets every year, allowing ease of access for our limited partners to invest to help us make something better in healthcare. Some of the benefits of Jumpstart Foundry is there's no management fees. We deploy all the capital that's raised every year in the fund. We find the best and brightest, typically around single-digit percentage of companies that apply for funding from Jumpstart, and we invest in the most incredible, robust, innovative solutions and founders in the United States. Over the last 9 years, Jumpstart Foundry has invested in nearly 200 early stage, pre-seed stage companies in the country. Through those most innovative solutions that Jumpstart Foundry invests in, we also provide great returns and a great experience for our limited partners. We partner with AngelList to administer the fund, making that ease of access not only with low minimums, but the ease of investing in venture much better. We all know that healthcare is broken. Everyone deserves better. Come alongside us with Jumpstart Foundry, invest in making the future of healthcare better, and make something better in healthcare. Thank you, guys. Now back to the show.
All right, Vic, what'd you think?
I liked him. I think it's, listen, being in charge of digital transformation at an academic medical center like Virtua Health is a hard job, right? There's a lot of incumbent thinking and decades of practicing medicine a certain way, and he's tasked with transforming that. And I thought he was really open and great about like what he's trying to accomplish and how he thinks about it, and seemed pretty open to trying to figure out what the right answer is.
I was really impressed. I mean, a couple things. First, I was really impressed with his depth of knowledge on AI and just the different versions of AI, and being really clear and specific at the very beginning of our conversation that LLMs are not appropriate for the clinical theater today. Yeah. I thought that just getting that off the table so we could have a deeper conversation was great. I thought the whole thing about the Virtua approach to digital transformation in terms of their business model, how they'll go in and try to take 3 years of change and accelerate it into 6 months, and then turn it off if it doesn't work, or keep it going and fully fund it as a new business model if it does work. I thought that was really, really unique.
Yeah, just having a leader that understands that we're going to try maybe 10 things in the next 2 years, and 3 will work, 3 we will have to do more work on, and 3 just won't work, and we're going to shut that down and keep going. That's what we need as VCs. I think that's what founders and management teams of startups need, is clarity and a partner to work through the business model and figure it out. Even if it's not the right answer, clarity is what's really needed.
What do you think? What do you think is the likelihood that this pilot that they're doing with Wobot will actually be able to get real movement with payers? I thought that was another really interesting part of what he shared was that they don't yet have codes
Right.
for this. So they are partnering to demonstrate that in a, total cost of care model, this actually improves care for the patients, lowers the total cost of care. And just even, give me your feedback on what you think the likelihood of this actually making the payers sort of adjust their thinking around how they would pay for this form of care. But then secondarily, I would love to know your thoughts on just the model of health systems partnering with digital therapeutic companies to prove efficacy and then make a case to payers. Like, I thought that was, that felt like a big deal for the whole digital therapeutic space, right? That we have health systems that are willing to partner with innovators and then collaboratively go to payers and make a case for value.
Yeah, I think that is a great model that honestly I had not seen before. Tarun educated us about it. I think it makes a lot of sense to go sort of in partnership, a large-ish health system with a tech startup as a partnership, saying, here's the outcomes that we have done kind of on our own account with our own money and bringing results to the payer. I think that model has a lot of promise. How it will be received from the payers is unknown, but hopefully they will look at the data, and if it delivers better outcomes at lower costs, they should fund it.
Yeah, I felt while I was listening to him like, I was watching a star rising. Like, I kind of feel like this guy is going to be a big deal in the healthcare innovation space. Like a lot of people may not know him yet, but I think more and more people are going to get to know him.
2 weeks ago, and then I had never talked to him before today.
Yeah,
and he's great. And it's pretty hard. I mean, to sit in that transformation seat and work with all the physicians, and he characterized it very well. They're trying to deliver care. There's all this new research coming out daily that's very hard to keep up with. And how can he be kind of an advocate for them, as well as an advocate for new technology innovations that need an audience, need to be tested. Now, whether they work or not is, like I say, 3 out of 10 will work. Maybe 3 more will need to be iterated and improved on.
Mm-hmm.
But just having someone who can bridge that gap, there's not a lot of communication between the existing infrastructure in healthcare systems and the innovators that understand the technology, but really maybe don't understand the day-to-day life of a physician. Yeah, so I think it was phenomenal, and I think he'll get. I'm sure there'll be people criticizing it, but I was really impressed with his approach and kind of how he's thinking about it.
What did you think about the case that he made? He made, I thought, 2 very compelling cases. One case, which is that we ultimately really need to get to automation in the clinical setting, because of workforce, because of expansion of medical knowledge, because of the out of whack ratios from a labor perspective versus aging population. So I think he made a compelling multi-layered case for the fact that while we're not ready today, we are going to need to get ready, because there's no other way to care for our communities if we don't do that. And then at the very same time, positioning sort of the psychological challenge of humans having an acceptance of the fallibility of other humans and being okay with the number of deaths that we have. I mean, we're not okay with it, but we understand humans are fallible. But even if we were to improve the metrics, are we going to be okay with machines being fallible? So like, I thought that there was an interesting crossroads we're coming to, where just logistically, from a viability perspective, we're going to have to automate more things in the clinical setting. And at the very same time, how are we going to get comfortable with the reality that we are going to likely improve things overall and still have mistakes that lead to death?
Yeah, I mean, listen, in a healthcare system, you're going to have patients that pass away. I mean, that's just part of treating really sick, high acuity patients in a healthcare setting.
Yeah.
And I think there's a social dynamic that we need to restructure in our society. If a human error causes natural, there's going to be 1% of this procedure that ends up in a bad outcome. And we've lived with that forever. And that's just part of the delivery of care. If you then shift to half that, 0.5% will have a bad outcome, but it's a technology-based thing. The liability, the legal liability structure and kind of whose decision was made, how do we place blame, how do we decide when to implement that and not? We just don't have the language or the legal structure or the payer and provider infrastructure to do it. So I think part of what we have been saying has become more crystallized to me, that the existing structure of health systems deliver care and then payers adjudicate whether that was right or not and pay for the procedure when it's right, that is outdated and needs to change. And so whether it is a sort of a holistic value-based system where you have all risk under one platform or there's some other combination, basically I took away that we need new structures, new legal frameworks, new payers frameworks, new ways to deliver care in order to take care of our population.
Yeah, very much. Anything else you want to say just as in the debrief before we move on to the news of the week?
No. I mean, we've already said it. I'm excited to see how it goes. I think he said he would give us an update in 6 months or so.
Yep.
So it'll be good to follow it. And I think part of what I want to do on this podcast is find innovators like him that are doing great things around the country, and then get to know them and follow them and try to learn from them so we can take best practices to other health systems.
Yeah, I'm definitely smarter for having had that conversation.
Yeah.
So thank you, Dr. Kapoor. And thank you, Bruce. We got to have Bruce on the show as well.
Yeah.
He's doing some really cool stuff as well. So we got to catch up with him and get him on the show.
Yeah,
All
and
right.
I think we're going to have more guests. I mean, bringing in outside perspectives is good.
Yeah, don't spoil it though. That's part of our surprise for next year. All right. So quickly, the White House continues to be very, very active. And Vic, you pointed out that we're basically a year away from Election Day.
Right.
So it's time for them to start packaging things up. And so they released the United States Playbook to address social determinants of health. This is the second big announcement that they've come out with in 2 or 3 days on the healthcare front. But the last one we covered last week was the women's health research announcement.
Right.
And basically, I think we looked through the actual PDF and it felt to us like it was largely packaging a philosophy, the existing body of work that they've done, over the course of their administration that kind of falls into the buckets of addressing housing security, food security, education access, and a healthy environment. And then they provided a playbook of actions, 3 pillars. The first, expand data gathering and sharing. The second pillar is support flexible funding for social needs. And the third is support backbone organizations. So it's kind of like, a thought leadership white paper. It's not really an executive action. It's kind of like a framework that feels like it's part of a policy framework that they will use in the campaign trail.
They're laying out their healthcare platform.
Right.
And I think that's probably smart politically. There wasn't a lot of newness in this.
No.
I mean, SDOH was all the rage 5 years ago, maybe 8 years ago. And I think it's fairly consensus now that these factors are determinants of health and we have to address all of them. Didn't feel that new to me, but it is sort of laying out the Biden administration's work to date and where they want to go, which is, net positive. Yeah.
I think frameworks are sometimes as helpful as actions, right? Help us understand how you're thinking about this. What are the structured steps or actions that you are taking and that you want to encourage others to take? And what's the guidance you're providing for your, canon of agencies to go after this? So I think I agree. It's not action oriented per se, but the framing of it such that we can all have, scaffolding to have this conversation and to understand how they're thinking about it and maybe how this might filter into a set of innovative actions that companies will take, the CMS might package up into codes, that's all pretty helpful.
Yeah. I mean, I think it's like research into women's health last week. These are initiatives that I mean, it probably has 95, 100% approval ratings.
Right.
So it's a smart political thing to do.
Yeah. Yeah.
It's not that there's not a lot of new there, but positive.
All right. So now on to the story of the week.
Yeah.
And, potentially the story of the year. And who knows, in the future, this could be a historic moment. And I feel like every time we're talking about AI, and specifically we're talking about OpenAI, I keep saying like historic. But I just feel like I've got pattern recognition around massive shifts in society as it pertains to technology. I'd certainly believe LLMs, and especially the OpenAI version of LLMs, represent that. And my gosh, we have had a week at OpenAI. So,
Yeah.
Okay, do you want to just start by trying to recap it? Because here's the thing. I don't want to assume that all the listeners know exactly what's happening. I was talking to my wife, and I've been basically keeping her up to speed, and she's very aware of what's happening in technology. So let's maybe start with a rundown to get to this point.
So let's do kind of a fact-based over the last week or so without a lot of conjecture.
Yeah.
So
yes,
the OpenAI Developer Day was 10 days ago, 14 days ago. We covered it here. I believe that unveil, which we talked about, lots of new products, really powerful products.
GPT-4 Turbo, custom GPTs, lower prices.
Giving out like API and the GPT to like
robust plugin
giving
development.
Power to lots of people that don't work at OpenAI to use and work with.
Yep.
We were excited about because it was clearly powerful. It seems like that was the last straw. Whatever the reason is, the board of OpenAI, which is an independent board, there's 4 members. They're not investors. They are in place to guard the nonprofit mission of OpenAI. The structure is a nonprofit foundation, and its mission is to bring AI to humanity and protect us from AGI, which it would be an automated intelligence that is smarter than humans, because
artificial general intelligence, which is the same kind of intelligence humans have, not a specific intelligence, but general intelligence.
Yes. And so I don't think anyone believes that ChatGPT or the LLMs are there yet.
No, they do not represent AGI as we have experienced them.
That's right, as has been shown to the world so far.
Yes.
But the trajectory, the capacity and capabilities of the large language models is, as we've talked about, is increasing very quickly.
Yes.
This board is in place to try to protect from really bad outcomes, like it turning on humans and killing us all.
Okay.
So there's a foundation, then there's a nonprofit subsidiary. I mean, there's a for-profit subsidiary, LLC, that has been charging people $20 a month and making all this revenue, and has done the deal with Microsoft and lots of other VCs. And they fired Sam Altman Friday afternoon because, in their opinion, he was not being forthright, not communicating openly and honestly with the board. And like all CEOs, he reports to the board, and they have the power to fire him.
And so they did.
So they did Friday, and he was shocked, I think, and was on Twitter X.
The whole world was shocked. Let's just,
Yes. And there was a effort for them to take him back. And Microsoft was pushing that. VCs were pushing that all invested in the subsidiary. And then they refused to do that because Sam, I think, demanded the board be replaced, as any CEO would after they fired him. And then they brought in a new CEO Sunday, I think. And simultaneously, Microsoft extended an offer of employment to Sam to join Microsoft. And then Sunday or Monday, a letter with about 700 of the 770 engineers, developers, signed by 700 of them, so like 90% of 80% of them, saying that they would leave the business if Sam wasn't reinstated. I think that's the summary of the facts.
Yeah, I think the only thing you may have left out was that the president of the organization, is it Greg Brockman? Is that his name?
Yeah.
He quit. He quit the board and he quit the company.
Yeah. He
publicly.
voted with the board.
No. You're talking about Ilya.
No.
No.
So let's distinguish that.
Greg was alongside Sam. He was not fired, but he quit.
He quit
He's summarily quit. Ilya, who is the chief scientist, was on the board and was part of the vote.
Yes, and he has gone back and said he's sorry about that vote.
And signed the letter.
Right, exactly.
And there are various threats from the investors who invested in the for-profit OpenAI business to sue the board and the foundation. Is that correct?
There's lots of threats.
Lots of threats flying around.
Yeah.
Right. Because there's assumed serious value destruction that has happened at OpenAI. And that was at one point, maybe Friday, reflected in Microsoft's stock price. And then over the weekend, Satya Nadella pulled another all-time great move, brought Sam Altman into Microsoft, and then Microsoft had their all-time best day.
Yeah, on Monday.
On Monday.
Yeah.
And so we are recording this Tuesday.
Yeah, with the holiday.
Early
Tuesday,
evening.
Right. So it's changing quickly.
By the time this goes out, I mean, everything we said could be reasonably outdated.
Yeah. So those are the facts as we know them now. I think we should talk through conjecture or that aren't facts, but what we think. I mean, this article in the Atlantic that we'll post, it may be behind a paywall, but
it's behind a paywall. So if you want to read it, you'll have to pay.
I mean, there are 100 news stories, but I think by far the best reporting on this is by the Atlantic, and they go back to before the release of ChatGPT, and then sort of talk about all the sort of circumstances leading up to Friday, and it's pretty good reporting. They have 10 sources in the company. They're not named because they wouldn't give their name, but it seemed like a very well-researched, good news article. And in the news article, they make the case that the board took their job of protecting humanity from AGI seriously and began to get concerned when they released the first chatbot, which was amazingly not quite a year ago. So it was on November 30th last year, so less than a year ago. And it was released, we should probably get the quote, but as a low-profile research project. And a lot of the reason it was kind of rushed to market is their competitor, Anthropic, was about to come out with their chatbot, and they wanted to get in front of that. And so a low-key research preview there.
Yeah.
And so this was the biggest and highest profile product release in the history of product releases. Now, whether that was intentional or unintentional, there was nothing low-key about it. And so I think the article is suggesting that the board was nervous about the lack of control that OpenAI had over this. So they have a tool that is supposed to be monitoring the traffic and seeing, for instance, are people using this for malicious purposes? Are they trying to figure out how to create a bomb out of kitchen supplies or other stuff like that? And they built a tool that could supposedly follow the traffic and try to find bad actors and cut them off. And the tool was designed for like 100,000 users at a time because no one thought they'd have that many users. And it it's 100 million a week now. And so their safety controls were completely swamped. And there's been a group inside OpenAI that is concerned. And I've heard, you've probably heard, there was a letter signed. There are people that are in the world that are worried about AGI getting out of control. I don't have those concerns, but there are serious researchers that have concerns about that. So it is a thing, and OpenAI was designed to protect against that. And so then they released GPT-4, which again was not, the board didn't want to release it. And so I think my guess is that they saw sort of the power that the for-profit sub was getting and felt like if they didn't stop it now, they were not going to be able to fulfill their mission. Now, whether that was right or not, the board is pretty powerful, and I think it's going to be a challenging lawsuit. So,
yeah. So, I mean, I think we have a very complicated story because we have a nonprofit and a for-profit and a groundbreaking revolutionary technology in our hands. That's kind of the recipe that creates what we've experienced over the last 4 days. A nonprofit that has an altruistic charter of protection in mind, with a technology that, look, we've made movies about this, and not just one, right?
Yeah, hundreds. Yeah.
We've made a lot of movies about this potentially being what ends the world as we know it. So I, for one, appreciate the idea that someone is trying to make sure that this thing doesn't get totally out of hand. I think safety is appropriate given the potential power of AGI. But commercial actors are at play. It takes money to run these kinds of things. You're going to get commercial interests if you need money to advance things. And I think that you can't serve two masters. And so I think the idea that this, most powerful version of AI in at least the Western world was being built in a house divided, nonprofit on one side, for-profit on the other side, with Microsoft hanging sort of in the wings, staking a major part of its future on this. It was kind of inevitable that some type of fissure was going to happen. I think the way that it happened was totally surprising. But now let's just talk about the implications of Microsoft potentially acqui-hiring Sam Altman and a ton of these engineers without having to buy the company. I mean, Satya Nadella has made incredible deal after incredible deal and really resurrected Microsoft, not just in stock performance, but I think in brand sort of eminence. I mean, the brand of Microsoft is a great technology brand again, and it wasn't for a long time. Steve Jobs almost buried that brand.
No,
Steve Jobs. Steve Jobs.
Apple sort of.
Yeah, Steve Jobs. Not Steve Ballmer. Steve Jobs.
Steve Ballmer sort of just like kept it going.
Yeah, he just kept it going while Steve Jobs was burying it. Right. And this guy's brought this brand back to life, and he hasn't done it all through internal effort. He's done it much through M&A.
Yeah.
Right.
I mean, GitHub was brilliant.
GitHub, LinkedIn, Activision. Now he's got Call of Duty and OpenAI. I mean, just look at that cohort of brands, of technology brands.
Yeah.
And now the idea that he may be able to get the brain trust without having to buy the asset is just, it's just mind-blowing. And I think the other thing is, what other situation would create an incentive for Sam Altman, who clearly has the heart and mind of this team, to go with the incumbent rather than to go take a bunch of VC money and do this on his own at unbelievable terms? And the answer is hardware and network, right? I mean, we're now in this era that clearly shows the power of Microsoft, Google, Facebook, Oracle, right? These companies that have cloud infrastructure, global cloud infrastructure, they have a different kind of currency than they had in the pre-AI world of tech. And I think that sort of lends into this next story, talking about how VCs have been aping into these AI deals, not really recognizing all the platform risks that are there when you're trying to base everything on AI. But before we get into that story, I mean, just
I think just going back to the structure. I've done this for a long time. I've been a VC 23 years. I've never seen this kind of structure before, where you have a nonprofit with a subsidiary that is worth any significant amount of money.
Right.
It was worth
much
90
less.
billion or 100 billion or
Right.
something. And is the world leader in a technology that is changing all these markets. It probably wasn't the place to try new things and try to reinvent a corporate governance structure. But that's what they did. And it is, I think, it's symbolic that Elon Musk was an early backer and then pulled away because he didn't like the direction it was going. The Anthropic founders were founders in OpenAI, and then they left to start Anthropic. The platform was started with a mission that I don't think Sam Altman as CEO really fully believed in. He was much more aligned with the for-profit. And I would probably be the same. But that probably means he wasn't the best person to be CEO. And it's going to be chaos now. I think Microsoft will likely gather, say, half of the developers. But Benioff from Salesforce is doing an open call. Musk is doing an open call. It's like a free-for-all trying to grab talent. But the source code is not owned by those people. They're going to have to leave the source code there. And I don't know exactly what that means for Microsoft. It's going to be a little while for them to get going if ChatGPT falls apart or is just a shell. So I agree that Microsoft has played its hand very well, but I don't know that I would count Google and the others out that don't have all this chaos and have their team and can sort of go.
No, I definitely see this as an opening.
Yeah.
That's going to slow some of the momentum. That is a crack in the sort of veneer of how people view OpenAI in terms of, is it going to be the stable winner? Should I invest more time in Claude or Bard or Grok or kind of really start?
You have to have alternatives now because who knows what's going to happen.
Yeah. Yeah. And I just got an email from Google giving me a whole, slew of updates from Bard.
Yeah.
So look, it's going to be a race.
Yeah.
It's going to be a race.
And then
no question.
I agree with you that right now it looks like the compute infrastructure and cloud and the chips is a consolidator of power. There's only less than 10 organizations in the world that have enough compute to work with this. I'm hopeful that there'll be open source models that exist that allow for innovation in other areas, because that's better for the overall market, and selfishly, it's better for VC. But I think that is what it looks like right now, that the early movers are the people that have huge amounts of cloud compute.
Yeah, when you think about the power of the compute combined with the network, combined with the distribution, this feels like a winners take all kind of moment, unfortunately. So let's shift to this Wall Street Journal Pro story about VCs and how they've been aping into all the Gen AI deals. I do find it interesting. You, with your new fund, have certainly been focused on AI, but we've been very measured, I think, in our thinking around AI as it pertains to healthcare. It still has to have applicability. I think we know that the appetite to bring in AI is not evenly distributed, and it's not 100% here in healthcare right now. There's a lot of stories popping up right now about how payers are likely using AI for to accelerate denials of claims. But in terms of like health systems, I mean, look, we just talked to what I think is probably one of the most forward-thinking, chief digital transformation officers
who is
in
maybe
in
rightly
America.
going slowly in the patient care.
Yes, so. He was very clear. We're not ready for LLMs in the clinical environment yet. So anyway, having said all that, we know outside of healthcare, VC is almost entirely enchanted with Gen AI right now, and that has actually been pulling up valuations and deal count. Where outside of that, almost no deals are getting done. But you and I said pretty early that this feels like a winner's take all. I don't think this is a new take that we have, that Microsoft and Google and Facebook were going to be, the powerhouses in this space, and your ability. I mean, look, let's put AI to the side for a second, and we're about to talk about a company that I think is well positioned to fight. But Google Calendar came out with appointment scheduling last week, and it's like, holy crap, that's a total shot at Calendly, which was a unicorn. But it's like, it's a unicorn that was built on Google Calendar.
Yes.
And if Google Calendar gives you appointment setting for free, I think that's a lot of value destruction. If that was a publicly traded company, that stock would be down big time on that announcement, right?
Yeah.
It's a privately held company, so we're not able to see how that might impact the valuation, but there's no question.
The lesson is the same. It's still a significant threat.
That's right. And we're talking about a unicorn, by the way. We need to be clear. Calendly is a unicorn. So when we're talking about these Gen AI companies that are doing features, there were a lot of companies that were out there creating custom GPTs, and then OpenAI comes out with the custom GPT thing, and you're dead.
Yes.
That's it.
Yeah. So this article, I think, talks exactly to that, which is forever there's been kind of basic rules of the road in venture, right? Like, you should get some governance and control. Now, you may not be able to force things, but you should at least be at the table and be talking with the leadership. And there are a lot of times when VCs didn't get board seats. No one got board seats in OpenAI. Microsoft spent $13 billion and didn't get a board seat. So that's the first thing. But the second thing is exactly what you're saying, which is it has been a significant risk to rely on another company's technology that, like, you build on top of someone else's foundation. And I mean, Calendly and Google Calendar is a good example of that. There are hundreds of companies built on top of OpenAI, ChatGPT, and that brings risk. You're relying on another party's goodwill, and they can just decide at a moment's notice, well, we want that market now. Calendly, you showed us this is $1 billion market opportunity. We should take that. And it's actually better for the users.
Totally.
Why do I want to jump out of the interface I'm in right now?
And pay an extra $15 a month.
Right. And so that's a thing in venture that you want to have freedom to operate. You want to be able to build your own tech stack and not be subject to the whims of some other corporate partner, because their own strategy changes. And in AI, because of the capital needs, not many VCs, can't think of any that have, except for the OpenAI ones, that have invested in a pure LLM. They're all kind of building on top of these things, and that's subject to significant risk. And then the last one is typically, I don't want to fund large scale CapEx. Or like that doesn't pay that well, and the hardware, like buying CPUs, buying chips, buying hardware.
Got to support it, depreciates.
It depreciates like in a
terrible.
week.
Yeah, it's terrible.
It's not a good use of equity capital.
No.
So VCs forever have been using lease structures.
Hence the cloud.
Yes, right. That's what, exactly. So there were a lot of VC money that went into buying
chips,
NVIDIA chips. And I think that maybe isn't the wisest thing to do. So anyway, that it was just interesting to see the fear of missing out has caused all of these VCs to pile into this stuff and kind of giving up their own kind of best practices. I've been looking into it. I mean, I really am interested in the power of it. We have not invested in an AI company yet. I've looked at a ton.
Mm-hmm.
I did invest in a company that's sort of trying to work on the interface around communications in the post-acute space, which I think could be a really interesting data set. But right now they're not doing any AI. They're just sort of managing that communication flow. One of the things that I think is an opportunity is getting unique data sets in healthcare where you have a patient population or you have a physician, nurse, patient, payer population, and you have your own data that no one else really has, and no one else has organized in a good way. So you can sort of train the model for that particular narrow use case better than anyone else.
Right.
I think that's pretty interesting and is defensible and sustainable. I'm trying to line up some assets like in those positions that maybe could evolve in that way, but we have to see how it kind of pans out. So.
Yep. Well,
we'll see. I mean, it's going to be exciting next few weeks.
So listen, you've hung out with us for well over an hour now. So thanks so much for listening. Please share this with your friends. Go on your Apple Podcasts app and give us 5 stars. We are lining up some really fun stuff for y'all for 2024. Really excited about where that's all going, and hope that you all have a happy and very safe Thanksgiving.
Yeah, one of my favorite holidays.
Yeah.
Not much responsibilities. I'll eat a bunch and
lay around, watch football. Yeah.
Right.
Happy Thanksgiving, Vic.
Yes, you too.
All right. Bye, y'all.